Hello everyone, I am Dr. Abhishek Banerjee, Senior Lecturer in Oral Medicine and Radiology, BBDCODS, and I am here to discuss this topic of intraoral radiographic techniques, its advantages and disadvantages. So the contents are introduction, types of intraoral radiographs, type of IOPR, bisecting angle, that is bisecting angle and paralleling techniques, and the comparisons. Introduction. Intraoral radiographs still remain one of the most important imaging modalities available in dentistry. Intraoral techniques provided high spatial resolution imaging of the tooth and potential associated dental and jawbone diseases. When careful attention to calibration and with meticulous techniques, the film receptor positioning intraoral radiographs yield the essential diagnostic information. The types of intraoral radiographs are periapical, bite-wing and occlusal radiography. Intraoral periapical radiographs IOPR are widely used for the preoperative planning and evaluation for most minor oral surgical procedures owing to its simplicity, significantly low cost, less radiation exposure and easily availability in the dental clinic setup. Indications are apical infection or inflammation, assessment of the periodontal status, after trauma to access the teeth and alveolar bone, assessment of the presence or position of unerupted teeth, assessment of root morphology before extraction, during endodontic therapy, then preoperative and postoperative appraisal of apical surgery, detailed evaluation of apical cyst or other lesions in the bone, and assessment of the position and prognosis of implants. The limitation is it is a 2G image and cannot be taken in cases of trismus. Gagging is a common problem and a large cyst or tumor cannot be seen in a single radiograph. IOPR techniques, there are two techniques, the bisecting angle technique and the paralleling technique. The bisecting angle technique was used often in first half of the 90s but has been largely replaced by the paralleling technique. This method was useful when the operator was unable to apply the paralleling technique because of its large rigid sensors and because of the anatomy of the patient. It follows the Szymanski rule of isometry. This is the Szymanski rule of isometry. The central ray, it is perpendicular to the line bisecting the long axis of the tooth and the long axis of the film. Receptor holding instrument. So the instrument used is known as snap array holder, and in this picture B is a snap array holder. Position of the patient. For radiograph of the maxillary teeth, the patient's head should be positioned upright with the sagittal plane vertical and the occlusal plane horizontal. And in the case of mandibular teeth, the head is tilted back slightly to compensate with the change in occlusal plane. Receptor placement. The receptor is positioned behind the area of interest with the apical end against the mucosa on the lingual or palatal surface. Occlusal or incisal edge is oriented against the teeth with an edge of the receptor extending beyond the teeth so that we should get the image of the teeth, full image of the teeth. Care must be taken not to bend the film excessively. The position indicating device or the PID. In case of the PID is provided, then the proper angulation can be given. But however, when a bite block or other devices without aiming ring is employed, the radiographer must determine the horizontal and the vertical angulation on its own. The horizontal angulation in this direction of the central ray in the horizontal direction, that is side to side plane. Horizontal angulation should not differ according to the technique. The correct horizontal angulation, the central ray is directed perpendicular to the curvature of the axis and through the contact areas of the tooth. As a result, the contact areas remain opened. In incorrect angulation, there is overlapping. Then the vertical angulation. The vertical angulation refers to as the positioning of the PID in the vertical or the up and down plane. And for different maxillary and mandibular tooth, the vertical angulation, it changes. Advantages: it can be used without a film holder with an anatomy when the anatomy of the patient pre-occludes to the use of the film holding device, and reasonably comfortable, simple and quick for the patient in all parts of the mouth. There is a decreased exposure time because short PID is used, and all angulations are assessed correctly. Then the tooth is of the same size as of the original image. No special sterilization procedure is required. The disadvantages is image distortion is very commonly seen in this procedure. Angulation problems is always there because of the aiming of the film holder. Incorrect horizontal angulation will result in overlapping of the crown, or maybe and vertical angulation will cause film shortening or magnification. When the patient holds the film with the hand is also exposed, and the periodontal bone levels are purely represented. And in maxillary tooth, in cases of the upper molars, the shadow of zygomatic bone frequently overlaps the roots. The buccal root of premolars and molars are foreshortened. The crown of the teeth are often distorted, thus preventing the detection of proximal caries by this process. It is not possible to obtain reproducible views. Then second is paralleling technique. The essence of this technique is the X-ray film is supported parallel to the long axis of the tooth, and the central X-ray beam is directed at right angles to the tooth and the film. To achieve the parallelism between the film and the tooth, the film is placed away from the tooth and towards the middle of the oral cavity. Because of the anatomic configuration of the oral cavity, that is the curvature of the palate, the object film distance must thus be increased. Because the film is placed away from the tooth, image magnification and loss or definition results. See, the target film distance is 16 inches. That is why it is known as the long cone technique. 16 inches target, so it is known as the long cone technique. Receptor holding instrument is known as the RIN XCP holder. X stands for extension, and C for cone, and P for paralleling. Receptor placement. For the best image, the receptor should be positioned parallel to the teeth and deep in the patient's mouth. The maxillary projection and superior border of the receptor generally rest at the height of the palatal wall in the middle. For mandibular projections, the receptor should be used to replace the tongue posteriorly or towards the midline to allow the inferior border of the receptor to rest on the floor of the mouth away from the mucosa on the lingual surface of the mandible. Angulation. The angulation orientation of the X-ray machine is aiming cylinder is vertical and horizontal, should be adjusted to align the aiming ring, and this prevents any overlapping of the image. This is the technique that is used, paralleling technique. Advantages are accuracy. The radiographic image is free from distortion and maximum details and definition, and there is no overlapping related to the structures as seen in bisecting angle technique, that is the shadow of zygomatic bone. Simplicity of the technique. It is easy to learn and use. Alignment device eliminates chances of dimension distortion, and duplication is easy in these cases. And there is decreased in secondary radiation. Periodontal bone levels can be represented. The periapical tissues are accurately shown with minimal foreshortening and elongation. The crown of the tooth are well shown, enabling detection of proximal caries. The relative position of the film packet, teeth and X-ray beam are always maintained irrespective of the position of the patient's head. Disadvantage is placement of the film is difficult and causes discomfort to the patient. It is difficult to place the place adjacent, especially in cases of children. And within the mouth, it is difficult to place for inexperienced operators. There is increase in exposure time because it is a PID, the long PID. So exposure is more, and it is more space consuming. So difficult to manage in cases of small dental offices. Sometimes the apices of the teeth are very close to the edge of the film, so they are not well appreciated. Positioning the film in the third molar is very difficult. So called long, so the marks are sometimes short and leads to gross magnification and image produced. Holders need to be autoclavable. Then there comes bite wing radiography. Bite wing technique or the interproximal technique used to mainly examine the interproximal surfaces of the teeth. Indications are detection of interproximal caries, progression of dental caries, detection of secondary caries below restoration, evaluation of periodontal conditions, evaluating the alveolar crest, bone crest, and for the detection of calculus deposited in the interproximal areas. Principles is the film is placed in mouth parallel to the crown of upper and lower teeth. The film is stabilized when the patient bites on the bite wing tab or bite wing film holder. The X-ray film is then directed through the teeth and a vertical angulation of plus 10 degrees given. Film holder use is known as RINS XCP bite wing instrument. This is bite wing tab. It is an alternative of bite wing holder, and it is made of paper, hard heavy paper board tab. Occlusal radiography. This technique is used to examine large areas of the upper and lower jaw. The palate and the floor of the mouth may be examined. This is a supplementary radiographic technique that is usually used in conjunction with periapical or bite wing radiograph. Indications is to locate retained roots of extracted teeth, to locate supernumerary, unerupted or impacted teeth, to locate foreign bodies in the maxilla and mandible, to locate salivary stones in the duct of submandibular gland, to locate and evaluate the extent of lesions in the maxilla or mandible, and to evaluate the boundaries of maxillary sinus. To evaluate fractures of maxilla or mandible, to aid in the examination of patients who cannot open their mouth more than a few millimeters, or the adult or children who are unable to tolerate the periapical film, and to examine the cleft palate, and lastly to examine the change in size and shape of the maxilla and mandible. Classification is occlusal view are of cross-sectional, topographic and pediatric. And topographic can be divided into anterior and posterior, which is also known as lateral. Basic principle is the film is positioned with the white side facing the arch that is to be exposed. Film is placed in the mouth between the occlusal surface of the maxilla and the mandibular teeth. The film is stabilized when the patient gently bites on the film of the surface of the film. The maxillary occlusal film, the patient's head must be positioned so that the upper arch is parallel to the floor and the mid-sagittal plane is perpendicular to the floor. And in the case of mandibular occlusion, the patient's head must be reclined and positioned so that the occlusal plane is perpendicular to the floor. Maxillary cross-sectional view. In this, mainly the central ray is directed at a vertical angulation of 65 degree from the bridge of the nose, and the horizontal angulation is kept 0. Maxillary topographic view, that is anterior. In this, the central ray is directed at a vertical angulation of 45 degree and horizontal angulation of 0 degree. The central ray enters the patient's face approximately from the tip of the nose. The maxillary topographic view, that is a lateral. In this, we only see one half of the maxilla, or the inferior lateral aspects of the antrum and tuberosity, and the teeth from the lateral incisor to the third molar. In this, the central ray is projected to a point 2 cm below the lateral canthus of the eye and directed towards the center of the film with a vertical angulation of 60 degree. Mandibular cross-sectional view. In this, we can see the floor of the mouth and the lingual and the buccal plates of the jawbone and the teeth from second molar to the from second molar of right side to the second molar of left side. And it is directed at right angles to the center of the fins. The point of entry is middle through the floor of the mouth, approximately 3 cm below the chin. Mandibular topographic view for anterior. In this, the central ray is directed towards the middle of the film at an angulation of -55 degree and to the respect of the plane of the film. The point of entry is from the midline through the tip of the chin, and in this we see the anterior portion of the mandible from canine to canine and the inferior border of the mandible. The film is placed with the long axis parallel to the sagittal plane and far possibly as possible with pebbled side down. Mandibular topographic view lateral. In this, only one side, one half of the is seen from the floor of the mouth, buccal and lingual cortices, and also lateral incisor to third molar. In this, the central ray is directed perpendicular to the center of the film. The point of entry of the central is beneath the chin, approximately 3 cm posterior to the chin and 3 cm lateral to the midline.